Okay, last one, chapter 41, lower gastrointestinal system drugs. So, lower gastrointestinal system drugs treat a variety of issues. So let's talk about some of the disease processes. Let's get some content, some concepts to build upon for this learning. So, constipation, right? Hardened fecal material, it's difficult to pass for whatever reason, maybe some decreased motility as well. You can't go to the bathroom, you can't produce bowel movement. That's constipation. Diarrhea, loose watery stool. And then we have this weird IBS, IBD. Okay, so IBD is inflammatory bowel disease. These are diseases that cause inflammation in the bowel, potentially painful bloating, diarrhea, constipation. Crohn's disease and ulcerative colitis are the two big inflammatory bowel disease, or IBDs. IBS is irritable bowel syndrome. This is where you have the symptoms, the bloating, the diarrhea, the constipation, the having to run to the bathroom, all of that, the extra gas, but there isn't a disease process. There's no organic disease process that we found, like ulcerative colitis, where we have really, a lot of involvement of the intestines, and then Crohn's disease as well, where we've actually got some ulceration and some mucous membrane or lining issues, right? We're starting to degrade those. So types of drugs that we use for the lower GI system. For classifications, we're going to talk about aminosalicylates. We're going to talk about antidiarrheal medications. We're going to talk about anti-flatulent medications. And we're going to talk about laxatives, okay? So let's dig in. Aminosalicylates. So balzalazide, mesalamine, olzalazine, and sulfasalazine. Oh, I'm gonna try it again. Sulfasalazine. It's gonna come out eventually. So balsalazide, mesalamine, olzalazine, and sulfasalazine. Okay, there we go. If you have any questions about how to pronounce any of these medications, there is a pronunciation guide, thankfully, in the back of every chapter, because you're not going to get it from me. It's so hard to get some of them out of my mouth. I apologize. So aminosalicylates have proposed a topical anti-inflammatory effect on the bowel. So as they move through the bowel, they're able to decrease some inflammation. Really great for these IBD disorders. So Crohn's disease, ulcerative colitis, and also for irritable bowel syndrome. Adverse effects include abdominal pain, maybe some nausea, diarrhea, headache, dizziness, fever, or weakness. These are contraindicated, so don't give them to someone who's allergic to aspirin because of the salicylate component. Also, we don't want to give it to anybody allergic to sulfonamides, especially the sulfasalazine, right? Because it's a sulfa-based drug. Someone who has intestinal obstruction, it's not really going to help with the inflammation for them because they have a clog, right? And then not good for anyone under 2 years old. Be careful with pregnancy and lactation. And interactions include digoxin because of decreased absorption of the digoxin, methotrexate because of increased risk of immunosuppression, oral hypoglycemics due to risk of actually increased blood glucose, which is very different, right? And then warfarin, which is your anticoagulant because of the increased risk of bleeding. So for people that have IBD or inflammatory bowel disease, they also may use biologics. So a couple of those include adalimumab, which is Humira. You've probably seen a commercial for that one at some point in time, and infliximab, also Remicade. Very, very common biologics. These are actually going to decrease the body's immune response. And we know that Crohn's disease and ulcerative colitis can be immune mediated. So if we decrease the immune response, hopefully we're also decreasing that inflammation and producing some relief, right? But whenever we're decreasing the immune system, we're also increasing our risk of infection. So the big thing with biologics is that we increase our risk of infection when we administer them. We also may use miscellaneous drugs for IBS or IBD, things like alloxitron, alvimapan, eluxadiline. I'm gonna try, guys. Liniclonide and methylnaltrexone. So these are good to treat those GI signs and symptoms. Maybe they're adverse effects, but they're good to treat some of those GI issues like irritable bowel syndrome and inflammatory bowel disease. Okay. Not a huge stressor on these two categories, just something that you should probably know going into like Pharm, Proctor, and Exit. Antidiarrheal medications. So some examples of antidiarrheals: Pepto-Bismol, right? All those things. Nausea, heartburn, indigestion, upset stomach, diarrhea. It's Pepto-Bismol. So bismuth is an antidiarrheal. Also, diphenoxylate with atropine is Lamodal, very common antidiarrheal medication. And the last one, loperamide. I would encourage you to circle and star loperamide and Imodium. Loperamide is an antidiarrheal that decreases motility. It is a medication used for diarrhea, maybe diarrhea from IBS or IBD, maybe diarrhea from a chronic condition like HIV or AIDS, maybe a side effect of a medication, or maybe diarrhea caused by that terrible bacteria C. difficile or Clostridium difficile that causes C. diff, right? We want to stop that kind of diarrhea because it can cause dehydration. So most of the time we don't stop bacterial diarrheas, but in C. diff we do because it's extreme and it can cause extreme dehydration. So adverse effects include anorexia, nausea, vomiting, constipation, abdominal discomfort, pain, distension, dizziness, drowsiness, headache, sedation, euphoria, fun fact, and rash. Don't want to use this in someone with like a viral infection. So if they have like a GI virus, we kind of want it to run its course. So we let that diarrhea kind of happen, right? We want to get all that out. But with the C. diff, we definitely want to see it stop the diarrhea. Less than 2 years old, this is not a medication for you. We're not going to give you an antidiarrheal medication. We want to be careful with C. diff that's causing pseudomembranous colitis, but most of the time we are going to go ahead and prescribe an antidiarrheal in order to prevent dehydration. Abdominal pain of unknown origin, we got to figure out what's causing it before we try to stop it. And then obstructive jaundice, because we want to get all of that bilirubin out. So we're not going to stop the diarrhea. Interactions include antihistamines, opioids, sedatives, and hypnotics because of an increased risk of CNS depression when combined with antidiarrheal medications. Also, antihistamines and antidepressants can increase those anticholinergic effects, okay? So watch out for that. And the MAOIs with antidiarrheal medications can increase the risk of a hypertensive crisis. MAOI is not hypertension, man. We don't play with that. Okay, antidiarrheals, they should stop the diarrhea, right? Lamodal, Imodium, okay, loperamide, those are some of your antidiarrheals. Anti-flatulence, so flatulence is gas, so this is against gas, right? But really interesting fact, these don't decrease gas, they just increase the release of gas that they actually increase the release of gas. So they actually make you pass gas, hopefully by belching, but also maybe through some flatulence. And they prevent that buildup of gas in the stomach or intestines, which can be painful and also can allow it to happen multiple times, which is not maybe as convenient. Big ones, charcoal, which is also used, for things like overdose, right? Aspirin, activated charcoals are our friend there. And then simethicone, this is a big one. We use this for babies. We use simethicone drops. We also use this as a gas X over-the-counter pill. So uses post-op gas distension, dyspepsia, peptic ulcer, IBS, or diverticulosis. No real adverse effects of this medication. The only real contraindication is if you're allergic. Maybe be careful if you're pregnant with charcoal. But gas X is perfectly fine for even our pregnant people. And then the only real interaction that was notable was it when we use charcoal and mix it with other drugs, is going to decrease the effects of the other drugs due to decreased absorption, because charcoal is going to block absorption of the other drugs. So those are your anti-flatulence. And lastly, laxatives. And there's a whole bunch of different types of laxatives. So I kind of wanted to take an opportunity to break them down, what they do, and give an example of each. So bulk producing laxatives add bulk. So they add substance and water to the stool. This is good for both diarrhea and constipation. So if you have a lot of diarrhea, it's going to soak up all that water inside of that diarrhea and really bulk up that bowel movement. If you have constipation, it's going to pool water and hopefully provide enough water pulled into the bowel to allow a passing of the bowel movement. Beautiful example of this, psyllium or psyllium husks, that's Metamucil. You mix it in a little bit of orange juice or water, which we're going to find out in just a hot second when we do AdPi, and your client is able to use a bathroom. So that's great. We also have emollient laxatives. These really lubricate the intestinal walls and they help to soften the stool so that they can just slide on out. So things like mineral oil, right? Mineral oil lubricates it, makes it kind of slick, and that stool slides right out. Okay, stool softeners. Stool softeners increase water retention in the bowel. Let's circle this and star it, highlight it, draw some attention. Stool softeners increase water retention in the bowel. So they hold on to water instead of having your intestines absorb it back up into the system. And they add water to your stool. And by adding water to your stool, making it more runny, it is softer and easier to pass. Therefore, it's not going to cause constipation, right? So docusate or docusate sodium, also known as Colase, is a very great stool softener. They sell them over the counter, and they also can be prescribed by your doctor. Hyperosmolar laxatives like glycerin or lactulose actually dehydrate the tissues, which causes a little bit of irritation. And that irritation causes the bowel to contract. That's called peristalsis. And that contraction, that rhythmic contraction, peristalsis of the bowel, pushes the stool along, resulting in an evacuation of the bowels. Lactulose is also used for binding ammonia and helping the body to excrete ammonia so that people who are in like liver failure or have like cirrhosis don't end up with hepatic encephalopathy. Another laxative is an irritant or stimulant laxative. These are going to increase peristalsis by directly acting on the intestine. Senna or Senecot, right? That's the name brand of that, are going to be irritant and stimulant laxatives. Saline is going to attract or pull water into the intestine. You know, water always follows salt, right? So that's going to increase the peristalsis. Magnesium, milk of magnesia is a good example of that one. Okay, now that we talked about 6 types of laxatives, fun. Why do we use them? So stimulant, emollient, and saline laxatives can be used for evacuation before an exam. Maybe they're going to have a colonoscopy. Maybe we need to do a rectal or a prostate palpation, and we need to clear out the canal. Maybe there is a concern for something else, right? Some kind of like organic bowel disease. We need to clean it all out so we can take a good peek. Stool softeners, mineral oil are really great for preventing straining with bowel movements. So people that are quick to vagal and pass out, have syncopal episodes, people who have just had like a heart surgery, open heart surgery or something like that. We don't want them straining. Mommies that have just delivered babies, they have a lot of trauma down there. So we don't want to, cause any additional pain as they strain to produce a bowel movement. So stool softeners are great for those people, and so is mineral oil. Bulk forming laxatives is good for our IBS and our diverticular diseases to help to reduce the amount of liquid stool that they're having. And then hyperosmotic are great, like lactulose for hepatic encephalopathy that we talked about, right, to bind that ammonia. Adverse effects, maybe some GI issues, nausea, vomiting, constipation, diarrhea, all that stuff. Maybe some irritation or cramping related to the medication, potentially fading or dehydration, obstruction, particularly with that bulk forming laxative. Maybe it forms too much bulk and then it gets caught, right? Electrolyte imbalances. Contraindications include if you're allergic, if you have some nausea and vomiting, probably not the medication for you. You probably got something more serious going on, like an obstruction. If you have appendicitis, we don't need to do this. Impaction, obstruction, acute hepatitis. Okay. And then precautions, if you have rectal bleeding or you're pregnant or lactating, we want to be careful giving you a laxative. Interactions include mineral oil with fat-soluble vitamins, because mineral oil actually going to decrease the absorption of those vitamins. And then we don't want to mix milk, antacids, H2RAs, or PPIs with our bisacodyl, because it'll cause it to dissolve too early. So because of that enteric coating starts to break down. So let's wait at least 2 hours before we give bisacodyl after that milk, antacids, H2RAs, or proton pump inhibitors. Let's talk about ADPI, the nursing process, right? Assessment, you need to get a diagnosis and history of your patient. What's going on with your patient, medical diagnoses out of the chart, and what is their medical history. Get your baseline assessment of their symptoms. DX is diagnosis, HX is history, AX is assessment, SX is symptoms, right? You need to auscultate their bowel sounds, listen, palpate their abdomen, look for guarding, document their pain, have them rate it 0 to 10. Reassess after administration for relief of those signs and symptoms, right? Watch those vital signs. Watch to see how they respond to that medication. Be documenting your output, especially color, amount, and consistency of bowel movements. Big diagnosis here, risk for imbalanced fluid volume, right? Maybe they've lost too much because of the diarrhea. So that might be an issue. Or maybe the laxative is causing them to lose too much fluid. Optimal response would be our goal, right? We want to see you respond to the medication. We also want to prevent or manage any adverse reactions, and we want you to understand and comply with treatment as a patient. What are the things that we're doing as the nurse? Wow, look at that list, big old list. We're inspecting that stool before and after we give you the antidiarrheal. We're going to give you that bulk forming laxative with a full glass of water or some juice, right? Particularly like OJ. They like OJ or apple juice. We want to give mineral oil at night on an empty stomach, not on food. And we want to thoroughly mix any powder or granule laxative up. So that way they don't drink all the juice out of it or the water out of it. And there's a whole bunch of powder left in the bottom. They didn't get any of the medicine, right? We want to teach that the laxative may taste funny. We don't ever want to hide our laxative from our patient. We want to tell them, hey, this is your Miralax, right? This is your Miralax packet. I mixed it in this orange juice. Not just like, here, drink this orange juice. And they're like, this tastes funny. Like, no, that's not fair. That's not what we do as nurses. We give them the right to refuse their medications. So we tell them that it is their medication, and we warn them that, hey, this might taste funny. Sometimes laxatives have a little bit of a sour or bitter taste, maybe a little grainy, right? We want to notify the doctor if the temperature spikes on the patient or if that abdominal pain starts to increase, or it begins in the first place. They didn't have pain and now they do, because that would be concerning to us. We also want to notify the doctor if the laxative doesn't work. So if we're giving a medication to produce a bowel movement and they don't produce a bowel movement, we need to tell the doc something might be up. Maybe there's an obstruction or impaction that we're not going to be getting out without some more intervention, right? Strict I's and O's. Here's a big one, guys, and this is just a big one in life. Provide pericare to your client. Put on some bottom cream, some emollient every time they have a bowel movement. Don't make them sit in it. Obviously, this is going to take a lot of attention, especially if they've got chronic diarrhea. Just be willing to dedicate that to these patients so they don't have skin breakdown, because that can be debilitating. Also, teach our client not to drink alcohol or take other CNS depressants while they're on antidiarrheal medications. We know that can cause some issues with increased central nervous system depression. We also want to encourage our client to increase their water, increase their fiber, and increase their exercise, because we know bowels that move, bodies that move, their bowels move, right? With certain laxatives, the urine may end up being a different color. That's normal. So just depending on the laxative, make sure that the client's aware. And then if there's an anti-flatulent tablet, we want to chew that. Okay, chew that so that it works better to help to consolidate that gas. Expected outcomes, whatever we gave the medication for, we want to see that in the evaluation phase of the nursing process. We also want to see that any adverse effects were either mitigated or managed, and that the patient understood and complied with therapy. Okay, jumping down to these questions. Is the following statement true or false? The lower gastrointestinal system includes the stomach and small and large intestines. That is false. The upper GI system includes the mouth and the stomach, right? So the stomach's part of the upper GI system. The lower GI is the intestines, the small, then the large, the rectum, the anus, and any accessory organs are actually included in that lower GI system. So no, upper GI is mouth and stomach, not lower GI. True or false? Multiple over-the-counter products exist to treat GI systems. Well, that is 100% true. There's tons of stuff over-the-counter for GI issues like nausea, vomiting, diarrhea, constipation, etc. And the last one, absorption of both nutrients and fluid occurs in the intestines, as is the exchange of waste products. That's totally true. Lots of water absorption happens in the large intestine. Lots of nutrient absorption happens in the small intestine. And there is an exchange of waste products throughout. So that is chapter 41 in a nutshell. Your various drugs, laxatives, anti-flatulence, antidiarrheals, and aminosalicylates. I hope that was helpful. If you have any questions, reach out to me. Thank you.